Hi, I'm Josie Cowburn. I'm a family nurse practitioner with a doctorate in nursing practice, and I run Steady State Health, a telehealth practice focused on precision women's health in Oregon and Washington. I made this because I kept having the same conversation over and over with patients who came in completely worn down. They all had a very similar pattern. They'd seen other providers, their labs came back normal, they were told it was just stress or age or just what happens when you get older. They knew something was wrong. Nobody was connecting the dots. So today, I want to connect those dots. By the end of this, you're going to understand why ADHD gets harder as your hormones shift, why so many women in midlife go undiagnosed, and what it actually looks like to treat both things together, not as separate problems, but as part of the same picture. Let's get into it. Before we dive in, I'm a doctor of nursing practice and a board-certified family nurse practitioner. I'm a member of the Menopause Society and CHAD, the National Organization for ADHD, because in my practice, those two things are almost always connected. I built Steady State Health because I believe women deserve care that actually looks at the full picture: hormones, brain health, metabolism, mental health, treated together by one provider with one plan, not a referral to 3 different specialists who never talk to each other. I've been in the patient seat. I know what it feels like to be dismissed. That's why my practice is built the way it is. I want to start by asking you something. Does any of this sound familiar? Brain fog that won't lift even when you've slept? Mood swings you can't explain? Irritability that surprises even you? A quiet loss of confidence? Maybe even a harshness toward yourself that didn't used to be there? Things that used to be easy feeling suddenly impossible. Or maybe you are tired of how unkind your inner voice is to you. You go to your doctor, the labs come back normal, and you walk out with no answers. Maybe you've been told it's stress. Maybe you've been told it's just part of getting older or being a woman. Maybe someone implied it might be in your head. It isn't. And you are not alone. What you're experiencing has a biological explanation, and more importantly, it has a treatment approach that actually addresses what's happening. In the next 20 minutes, I'm going to walk you through 3 things. First, why ADHD gets harder in perimenopause and menopause, and what the estrogen and dopamine connection actually mean for how your brain functions day to day. We'll also talk about something I hear from patients often: realizing ADHD might be part of their story only after watching their child get diagnosed, or seeing something on social media that finally put words to an experience they've had for years. Second, how to tell ADHD from anxiety in midlife, and why so many women go undiagnosed for years before someone finally connects the dots. And third, what it actually looks like to treat both things together: hormones and brain chemistry evaluated as part of the same picture, not as separate issues requiring separate providers. By the end of this, you're going to have a clearer understanding of what's happening in your body and what your options are. So let's start with the biology. First, a couple of definitions. The key players here are estrogen and dopamine. Estrogen is a hormone that helps regulate the menstrual cycle, supports brain function, and affects mood, energy, and metabolism. It plays a key role in how the body and brain stay balanced, especially during reproductive years and menopause. Dopamine is a brain chemical that helps control motivation, focus, and reward. It's what helps you feel interested, driven, and able to follow through on tasks. Dopamine is the reason you check something off a list and feel a little. It drives motivation, focus, and follow through. The two are intimately connected. Estrogen is like the volume knob for dopamine. It helps your brain actually respond to it. When estrogen is stable, that system tends to function well. But in perimenopause, estrogen doesn't just decline, it fluctuates. It can drop sharply and unpredictably, which means the dopamine system becomes less regulated. Think of it as a radio that is too loud, which is overstimulating, or too quiet, where you really have to strain to hear it. Both are very frustrating. For women who have always had ADHD, even if it was never diagnosed, this can feel like suddenly falling off a cliff. The coping strategies that were working stop working. All the lists, reminders, alarms, routines that held steady for years start to collapse. And on top of it, medication may feel less effective. This is not a personal failure. This is neurobiology. Your brain changed because your hormones changed. And that distinction matters because it means there are real clinical options for addressing it. One of the things I hear most often from patients is some version of, I was managing fine for years, and then suddenly I wasn't. And they think that means something is wrong with them. What I usually gently offer back is this: you were managing, but you were likely working twice as hard as others to do it. Many women with undiagnosed ADHD have spent years, often since childhood, building intricate coping systems just to get through school, work, social situations, and home life. You learn to compensate, to mask, to push through. And that takes an enormous amount of energy, even when you don't realize you're doing it. What this slide shows is that the before and the after are actually two different biological environments. Before perimenopause, estrogen was relatively stable. That means dopamine was more regulated. The volume on the staticky radio wasn't going up or down chaotically. It was staying about the same volume. Your coping strategies were working, in part because the underlying chemistry was more consistent. During perimenopause, estrogen drops erratically. Sleep gets disrupted. Cortisol, your stress hormone, tends to rise. And all of that compounds on each other. The strategies that worked before are now operating in a much harder environment. Then, cue teenage children, aging parents, work stress, relationship problems, and health issues. Gradually, you may notice that you can't participate the way you used to. In conversations, in relationships, at work, you're less patient, you have less social bandwidth. The irritability starts showing up with yourself and the people you love. And then comes the part that I find most heartbreaking. You beat yourself up, even more for not being able to juggle it all, as if you were ever supposed to. Understanding this changes everything. Because it means the goal isn't to try harder at the things that used to work. The biological environment has changed, and the approach that was working, whether you built it consciously or just developed it over time, no longer fits the environment you're in. The approach needs to change with it. Here's where it gets complicated. ADHD and anxiety share a lot of surface level symptoms. Racing thoughts, difficulty relaxing, avoidance, mental exhaustion that doesn't go away even when you rest. And because anxiety is the more commonly recognized presentation in women, that's often what gets treated, while the ADHD underneath goes unaddressed. The things on the right side of the slide, difficulty starting tasks, time blindness, rejection sensitivity, working memory gaps, these are ADHD presentations. They're not personality flaws. They're not anxiety. And treating anxiety without addressing the ADHD is like treating the smoke without finding the fire. And often it's both. Anxiety and ADHD co-occur frequently. When estrogen drops, both can intensify at the same time, which is part of why this age range is so disorienting. Women are managing multiple things at once and have no framework for understanding how they connect. The research tells us that the majority of women with ADHD are not diagnosed until adulthood. Many aren't identified until perimenopause forces symptoms to the surface, and here's why that happens. ADHD in women looks different than it does in men or children. The hyperactivity is often internal, not external. Not always, though. I had both. My mother described me as a child constantly in motion. Women tend to develop strong masking behaviors, ways of compensating and appearing functional that can hide the ADHD from the outside, and sometimes from themselves. And this compensation often starts in childhood. We are taught from an early age to people please, to fit in, to not make things difficult. So we build systems and habits and personas that let us get through. Most of the time, we don't even recognize that we've been doing it. It just becomes who we are. A diagnosis finally occurs for various reasons. Often, when their children are diagnosed, some women feel as though a mirror has been held up. They can see their own struggles. Connecting the dots backwards, the kids that couldn't sit still, forgot everything, who felt everything too much. They didn't call it ADHD. They said things like, "You are so smart, you just need to focus," or "You are too much, too loud, too quiet, disorganized, spaced out." Maybe it felt like everyone else knew what was going on and somehow you missed the class that told you how to participate socially and pay attention. As they see their kids start to thrive, they consider a diagnosis for themselves. Another reason women pursue a diagnosis is when hormonal shifts in midlife reduce the effectiveness of those compensating strategies. The ADHD symptoms break through, and providers who aren't looking for it often treat what's visible, the anxiety, the mood, the sleep issues, without asking what's underneath. Without addressing both, treatment stays incomplete, and the patient keeps cycling through partial solutions that don't fully hold. They just hang on for dear life, hoping things will get better. So what does this look like to treat this well? Hormonal health and mental health treated the same by the same person, not separate referrals, not separate conversations. The same provider evaluating the full picture. The first visit includes a comprehensive intake, medical history, labs, a detailed psych and symptoms history, and what is currently physically occurring. We're looking at the whole picture from the beginning. From there, we build one plan with one clear timeline. I know that women coming in after years of fragmented care often feel overwhelmed by the idea of starting over. They may feel skeptical that this will somehow be different. The goal is to take it one thing at a time. Clear priorities, clear next steps, and adjustments made as your biology changes over time. That includes follow-up visits and ongoing messaging access, because this kind of care isn't a one-time consult. It's a relationship. A note on how both things are diagnosed, since I get this question often. ADHD evaluation at steady state health is a clinical assessment, not a single test. We look at patterns over time, your history from childhood through today, how symptoms have affected your work, your relationships, your daily life. We use validated questionnaires and screening tools supported by CHAD, the ADHD Society, and we assess for co-occurring conditions like anxiety, depression, and sleep issues. You do not need an extensive neuropsychological exam. Diagnosis is based on a clinical interview, validated tools, and the real functional impact on your life. Perimenopause and menopause are similarly grounded in your history and your symptoms. Labs are ordered when clinically indicated, but a review of what you're experiencing is always the foundation. Both evaluations are accessible. Both are focused on you, not just a test. Currently, assessment is offered in Oregon and Washington. I want to pause here because maybe you have never been diagnosed with ADHD. What does it actually take to be diagnosed? An ADHD evaluation is a clinical assessment, not a single test, and not something that requires an expensive neuropsychological exam. What it requires is a provider trained to identify symptoms highlighted in the DSM-5 manual for the diagnosis of ADHD. It is important symptoms were present before the age of 17. So we look at your history from childhood through today, how you function in school, past behaviors. Many women report a history of risk-taking, injuries, early pregnancy, bad relationships, and/or hyperfunctioning and people-pleasing. Some report spending years digging themselves out of impulsive mistakes as they become wiser. We also discuss how you manage work and relationships in daily life now. We use validated questionnaires and tools like the ASRS. We also screen for things that often co-occur with ADHD, anxiety, depression, and sleep disruption. The goal isn't to fit you into a category. It's to understand how your brain works and how your hormonal landscape is interacting with that. Nurse practitioners, primary care providers, psychologists, and psychiatrists can all diagnose ADHD when trained in evaluation. You don't necessarily need a specialist. You need someone who takes the full picture seriously. Diagnosis is based on a clinical interview, validated tools, and the real functional impact on your life. That's it. Accessible, straightforward, and it can change everything. Before we talk about what comes next, I want to bring it back to the 3 things I want you to leave with. First, your brain didn't break. Your hormones shifted. The estrogen-dopamine connection is real, and the cognitive and emotional changes you've been experiencing have a biological basis. That matters, because it means there are real ways to address it. Second, ADHD in midlife women is chronically underdiagnosed. Stigma, masking, atypical presentation, and symptoms overlap with anxiety means that most women aren't identified until their hormonal landscape changes and compensating strategies stop working. If you've been told your labs are normal and you're fine, that doesn't mean you are fine. It may mean no one has looked at the right things yet. Third, treating one without the other leaves you stuck. Hormones and ADHD are part of the same system. A whole person evaluation is the only approach that addresses both, and that's what care should look like. If any of this resonates with you, I want to tell you what working with steady state health actually looks like. For patients who have Oregon or Washington insurance, we offer standard visits billed through your insurance. These cover perimenopause and menopause treatment, ADHD medication management, metabolic health, and hormone panels when indicated. Care unfolds over multiple visits, each one building on the last to address these topics in the depth they deserve. For patients who prefer a self-pay path, we have two options designed for different stages of care. The first is Steady Start, a program designed for women who want a clear, thorough starting point. It includes an in-depth intake visit and targeted labs, followed by a dedicated follow-up appointment to review your results and build a curated plan for the care you actually need. It's a complete picture and a clear roadmap forward. The second is Steady Momentum, a 3-month bespoke program that begins with everything in Steady Start and builds from there. It includes a mental health evaluation with prescriptions when clinically indicated, and ongoing individualized care that addresses hormone optimization, sleep, metabolism, mental health, gut health, advanced testing options, and supplement recommendations. This is for women who are ready to go deep and stay supported as things shift. Not sure which is right for you? You can book a brief consultation and we'll figure it out together. I want to be transparent about a few things. Our self-pay programs are not insurance and cannot be submitted for reimbursement. We do not accept Medicare or Medicaid for these offerings. Care is available to patients located in Oregon and Washington. These programs are for women who are ready to stop guessing and start getting real answers. If you've been managing symptoms on your own, if you've been dismissed by other providers, if you've been told your labs are normal when you know something isn't right, I want to hear from you. The best next step is a brief consultation. It's not a sales call, it's a conversation. You tell me what's been going on, I'll tell you what I think, and we'll figure out together whether Steady State Health is the right fit for you. And because you attended this webinar, the consultation is free. You can book at steadystatehealth.org. The link is on the slide and in the description. Thank you for spending this time with me. I hope it gave you something useful, and I hope it gave you a little more clarity about what actually is going on. You're not broken. You just haven't had the full picture yet.